Welcome to Inflammatory Arthritis and its Treatments. This is Module 4, Advanced Disease Modifying Treatments. I'm Carolyn Wiskin, Clinical Pharmacist at Charlton Health in Hamilton, Ontario. We have two main types of advanced therapies. One being our biologic treatments. People often refer to these as BDMARDs, so biologic disease modifying anti-rheumatic drugs, big word. Biologics are protein-based medications, and for that reason we can't swallow them. They're given by either injection or an infusion. Then we have tablets that we can swallow that also are advanced therapies. They can work as well as these injections that we refer to as biologics, but they're synthetic. They're not made of protein. And these synthetic products are more targeted and specific. So they're giving us that greater level of efficacy, much greater than our conventional tablets that we talked about in the previous module. So let's dive into these both a little bit more. So what is a biologic? A biologic is a treatment which is made of protein, basically mimicking a protein naturally occurring in a human being. Our first biologic treatment was insulin. People who had diabetes and didn't make enough insulin, we wanted to give insulin to them. And initially we had to extract that insulin from the pancreases of pigs and cows. But then we realized, you know what, wouldn't it be great if we could make that insulin, make it identical to a human's? We didn't want to take it from another person. And so we actually programmed living cells to make insulin identical to a human being's. Those cells were bacterial cells, E. coli. But that's how people who receive insulin today, it is actually given to them, programming a bacterial cell to make insulin identical to our own. Pretty incredible. After that, we developed other biologic treatments, mimicking different human proteins to treat various conditions. So we have vaccines that are based on proteins in humans. We have many of our treatments for autoimmune diseases that are mimicking proteins in the human body. Of course, being a protein, you can't swallow that treatment because you would break that protein down and digest it in your gut, and now it would be useless. It wouldn't work at all. So all of our biologic therapies being made of protein have to either be injected or given through infusion. Let's compare our different types of treatments in looking at how complex they are to make. So if we were to take a traditional treatment, someone's on aspirin, someone's on acetaminophen, Tylenol, I would compare that really to a bicycle, something that would be very simple to make. Carbons and hydrogens put together in a chemistry lab, something that's synthetic. So basically, it's not that you're low in Tylenol and you top up your Tylenol level. You are taking that because man has created this synthetic substance that helps with pain and fever. We're grateful for it, but it's not mimicking a human structure. Then we get to insulin, which I previously mentioned. Well, compared to the complexity of a bike, making insulin is like a car. Wow, it's a lot more complicated. We have to take a living cell, as I mentioned, a bacterial cell in this case, and program it to make this protein. But now we get to the proteins that we make that trap and remove excess inflammation. And those proteins mimic the look of an antibody. You and I make antibodies. When you get a vaccine, you make an antibody against something you were vaccinated for. You get your flu shot, you make an antibody against the strains of influenza in that flu shot that year. And scientists thought that these antibodies, which are big Y-shaped structures where the top of the Y traps and removes the bacteria or virus that it was designed to remove, that they could make an antibody that would remove an inflammatory substance. So mimic what the body already does to remove things that it doesn't want, but create a treatment that would have that same concept, only removing an inflammatory chemical. And so when you are receiving some of the advanced therapies that are biologics, your body thinks it made it. It looks just like a protein that we could create. But to create that protein, we can't just use a bacterial cell and program it. We have to use a mammalian cell because it's a much more complicated protein to produce. And what we commonly use, we started with mouse cells. You certainly don't get any of the mouse when you get those products, but we program a mouse cell to make this protein and then purify it. We commonly now are using Chinese hamster ovary cells, believe it or not, and we're programming them to make many of the biologics we use today that are treating our autoimmune diseases.
Often we hear people mention fears when it comes to looking at advanced therapies. And I want to give you the opportunity to understand what some of the risks are when we don't treat, because truly the risk of not treating is greater than the risk of treatment. So when it comes down to vulnerability of infection, when we look at someone who is not treated and is flared, the body's exhausted. Inflammation levels are high. And so having a high level of inflammation in the system is exhausting. You're not as resilient and you don't fight infection as well. When we get you on a treatment that lowers your level of inflammation and puts you into low disease, if not remission, you actually can fight infection better. Your risk of infection will still be greater than the general public who doesn't have an autoimmune disease, but truly leaving you untreated and flared is a greater risk. And if we have to use prednisone to control a flare, prednisone has way higher risk than any of our biologic therapies when it comes to infection. Cancer risk, of course, would be a concern to anyone. But what we've learned over time and through registries collected around the world, that the increase in lymphoma that people were concerned about was not significantly higher than the risk conferred by rheumatoid arthritis alone. What that basically means is that there was no difference in people on treatment versus off treatment. It was in fact the condition that increased the risk. And however, I will say in people with rheumatoid arthritis, the risk of breast cancer is lower than in general public. The risk of bowel cancer is lower, but yes, lymphoma is a bit higher. The one risk that we do see in a very low amount is to skin cancer, and that's why we do say to have an annual skin check done. But nothing more is required than just an annual skin check that really we all should have. The other piece that has been mentioned is it more dangerous because it's injected? And it's not more dangerous being injected or infused. It's simply because it's made of protein, and that would be destroyed by the gut if you swallowed it. And heart disease risk. Well, active inflammatory disease increases heart disease. And the advanced therapies we're talking about can decrease that risk because they're decreasing inflammation, not just in the tissue that you feel and see, but also in the blood vessels as well. So getting your treatment under good control has way more benefit than it does risk. And this is why we make the decision to move on to these advanced therapies.
As mentioned, our biologic therapies, being proteins, can be administered in an infusion clinic. The infusion clinic is a comfortable environment, often with a big screen TV, Wi-Fi, snacks, often big bright rooms, and it takes it out of the more clinical hospital environment. These are clinics that are in the community, and so many people enjoy coming to them. They develop camaraderie with other people who are receiving similar treatments. Some of these infusions are monthly, other ones are every 8 weeks, and it's usually an hour to 2 hours depending on the treatment someone may spend in a clinic environment. So for some people, not having to administer an injection themselves, having the camaraderie and getting out and having a touch point with a health professional, the nurses in these clinics are very experienced with these therapies, is something that they really find important and valued. For other people who travel a lot, who have a busy schedule, being able to do an injection in the comfort of their own home is just a lot more convenient for them. And so it's nice we have both options because one may suit you better than another. When it comes to the injections that people can self-administer, all of these are what we call subcutaneous. And that means the length of the needle is very short. Sub means under, cutaneous means skin. So short little needle just going under the skin. And the majority of our options are available in auto-injector pen devices. Now, every company that makes a biologic for inflammatory arthritis does have their own patented design, but overall, they're very easy to use, and they can be given, in some cases, on a weekly regimen. We have others that are given every other week, and some that are even injected once a month. In many cases, these have equal efficacy, and so it really comes down to what meets your needs and lifestyle. Maybe weekly is what you need because you like the routine. You like the fact it flushes out of the body a little quicker than something that's once a month. Therefore, if you were to have any issue with it, although not common, it would be out of your system quicker. But there are many people who find that once a month, a busy lifestyle, they travel a lot, these are refrigerated products, they don't want to have to take it with them, they like that. And then others, right in the middle, the every 2 weeks is perfect for them. So it's wonderful that we have lots of options. We're going to start with weekly. So we have treatments that remove a specific inflammatory substance called TNF, or tumor necrosis factor. We know this inflammatory substance is really high in the joints of people with rheumatoid arthritis, psoriatic arthritis, and also ankylosing spondylitis. So treatments that remove TNF can be used for all 3 conditions. So let's look at the weekly ones. We have what's called etanercept, and it's marketed under 3 different names. Enbrel, which is once a week. We have Arelzi, also etanercept, the same substance. This is referred to as a biosimilar. And we have Brenzis. So all 3 of these, once a week, and they are the same product that is removing TNF. Let's just take a look at one of them. So here is the originator we call Enbrel. We would pull off the cap that's covering the needle inside. If this is mimicking the skin, we could be injecting this 2 inches either side of the belly button, tops of the thighs, or the back of the arm. We press this down, and then it is simply a press and release of this trigger button. The needle falls, and in this viewing window where you would normally see the clear liquid of the medicine, the plunger will fall. So you're able to hear a click that it's given and actually see the plunger come down. 10-second injection, the entire unit goes into a sharps container. It can never be put into the garbage. So when we looked at Brenzis, very similar, no trigger button, but it again is just a press and activate. And then we have the Arelzi with a little bigger viewing window. If we're to go with every other week treatments, we have Humira. And Humira has a cap that covers the needle on one end, and here's the trigger button. Same idea, little viewing window, press and release, about a 10-second injection. The other treatment that's every other week is Cimzia. It doesn't have a trigger button. It does have a large viewing window. It simply activates by pressure. Clicks again when it's finished. And then our once a month treatment known as Simponi, we remove the cap. It has a large trigger button. Here's the viewing window here. Press and release. So that's our once a month. So these we refer to as our anti-TNF therapies. Well, we have another family of these auto-injector units, and it is a family where the inflammatory substance that's removed is called interleukin-6. And we see that this inflammatory substance is high in rheumatoid arthritis, but we don't use treatments that remove this for psoriatic arthritis or AS. So I'm just going to move these aside and go back into my famous mortar here, my mortar and pestle. And I've got both the auto-injector for what we call Actemra, as well as Kevzara. These are treatments, again, are given, Actemra can be given weekly for people depending on their weight, or it can be every other week. So people of a lighter weight, every other week. People of a little larger weight, we would do a weekly injection. It is very similar with the trigger button at the end, clear viewing window, similar to what you've already seen. And then Kevzara with no trigger button simply activates with pressure. And this one is every other week. The other one that I wanted to show you is a different family again. And these are treatments that remove an inflammatory substance called IL-17 or interleukin-17. And we have 2 treatments in this category. They are used to treat psoriatic arthritis and ankylosing spondylitis. So here we have what's called Cosentyx. Again, no trigger button. It is simply a press and activate. You can see the plunger coming down into the large viewing window. And I'm just going to set that down because we've seen that demonstrated in style before. But I'm also going to show you what is called Taltz. Now Taltz is an auto-injector which has a little different setup. It actually has a safety lock. So when you are going to inject, you remove the cap at the end. You put this again against the skin, and then you turn this from a lock to unlock position. Then you can press the button. And in the viewing window below, you will see the gray plunger come into view. Again, these take about 10 seconds, even though the demos may be of a different timing. We have another, oh my gosh, don't we have a lot? We have another auto-injector that is used to actually reduce a chemical that signals cells in the immune system to prevent inflammation being made. And it has been approved for psoriasis for some time, but recently got approved for psoriatic arthritis. And it's called Tremfya. It is unique in that you remove the outer cap, the needle again is inside, but watch what happens. I'm going to press down, which will activate the needle that would come through. But then in order for it to be injected, you press down and you can determine the rate at which it's injected. At the end, the injection is complete. So this one, you control the rate of injection as well as it automatically putting the needle through. So these are examples of what we have, and there's more to come. So lots of options, all of them can be very effective. It's often a trial and error into which one we choose first, but in many cases, your input is valuable. What is going to meet your lifestyle, how frequently you want to give it, is it an infusion, an injection, what is the better option for you? We just looked at some of our biologic options that are advanced therapies. Now we're going to look at medication that you can swallow that's as effective as the injections we just talked about. And these are also synthetic. So again, made of carbons, hydrogens, can be put together in a lab. They're not mimicking proteins, and as a result, they can be swallowed. But these are much more targeted and specific in reducing the production of the inflammatory chemicals that we just talked about, the biologics trapping and removing. Instead, these go into the cells that are going to make those inflammatory substances and prevent the immune system signaling this production. So they're going inside cells as smaller molecules. They can be swallowed because they're not made of protein. So as effective, don't require refrigeration. Most of these are once a day. We have 3 of them in this category. And more effective than the agents that we talked about in the previous module are conventional synthetic, also synthetic, but these are advanced, more targeted, more specific, also more expensive, but these therapies are very effective.
Our 3 targeted synthetic therapies are tofacitinib, known as Xeljanz, and this is approved for both rheumatoid arthritis and psoriatic arthritis. We have a 5 milligram tablet that can be taken twice daily, or a newer 11 milligram long-acting tablet, which has been approved for rheumatoid arthritis. Baricitinib, or Olumiant, is a once-a-day 2 milligram tablet that is approved for rheumatoid arthritis, and upadacitinib, Rinvoq, is also for RA, and it is a 15 milligram tablet once a day. All of these are very effective therapies, but one thing I would like to caution you is that we do not take them with grapefruit or grapefruit juice, as it can affect the way the medication is processed and cause you to accumulate excess medication, as grapefruit blocks the elimination of these treatments from the system. Some of the adverse events that may occur with this group of targeted synthetic therapies could include headache or dizziness. Again, this is a low incidence. Runny nose, upper respiratory tract infections. We do see an increase in both good cholesterol, we refer to as HDL, and bad cholesterol, we refer to as LDL. However, one negates the other, and this still has a positive impact on the cardiovascular system because it lowers inflammation in blood vessels. So this raising of both good and bad cholesterol, again, one negates the other, so it is really not a concern to us. You may read about bowel perforation being a very rare side effect, and this has been seen in people with a condition called diverticulitis, where there's little pockets that form off the side of the bowel. These pockets can become a bit inflamed, and as a result, food is getting stuck in these pockets, and this lining is really thin. And that's the context in which we've seen this bowel perforation happen, is people with this specific disease, and this is a very uncommon outcome. Diarrhea, a bit of nausea can be seen with any of these treatments, but it is of a very low incidence, lower than the conventional disease-modifying treatments like methotrexate or leflunomide or sulfasalazine, but it can be for the first couple of weeks a little bit of adjustment for some people, which is why we say take it after food. Overall, I will tell you that these treatments are very well tolerated, and the risk of infection is no greater than the risk of infection we see with our biologic therapies. What we do recommend, which we'll cover in our next module, of course, is updating vaccines. But what we can say is that people on all advanced treatments, biologics, and these targeted synthetic therapies have more infection risk flared and untreated than they do on treatment alone. I do want to mention that the one infection risk that is a little higher with this therapy versus the biologics we just talked about is shingles. And as a result of that, as mentioned, the shingles vaccine is one that we definitely feel is worth having done before starting on therapy. We'll review vaccines in our last module.
So now that we've looked at our advanced therapy options, both injection, getting an infusion, or in fact doing one of our advanced tablet options, our targeted synthetic therapies, you may ask, how much are these treatments and how do I afford them and how do I qualify, how do I get them? And so there is a process by you getting these medications covered, because they are pricey, and that is by meeting specific criteria. So whether you have a private insurance plan or you're using a government-based plan, say a plan for senior citizens or a plan for people with disability or a plan for people that the government offers called Trillium, just because you don't have private insurance, whether it's a government-based plan or private plan, what they will ask for is certain criteria, and that is you've tried some of our conventional treatments that we talked about in an earlier module, and that they were not effective, that you still have active disease. So having that tender and swollen joint count done, having imaging done, whether it's x-ray, ultrasound, MRI, to show that joints are inflamed or there's been damage in those joints, doing the questionnaires, such as for ankylosing spondylitis, the BASDI, for instance, that we talked about earlier. So doing a different assessments, basically, to look at, is there inflammation in the blood? Are the joints tender and swollen? What is your level of pain or disease activity? What do our x-rays, ultrasound show us? If those are still showing active disease, despite trying less expensive conventional treatments, then that's what qualifies anyone to move on to one of these advanced therapies. And then the cost of these therapies is covered by these programs because you meet the criteria. And if you had a plan that covered 80%, 70%, the difference that's not covered, or a deductible you may have to pay with a government-based plan like Trillium, those are subsidized by the companies that make these medications. Each of them have a support program, and they have funding to offset whatever difference may be left from what your private or government insurance has paid. So the combination of government plans, private plans, and support programs from these pharmaceutical companies that make these products has allowed anyone who meets the criteria of having active disease, not treated by some of our other therapies, to get these treatments without it being an outlay of expense. And so nobody is really refused these therapies based on cost, which is a wonderful thing.
Based on a discussion with your rheumatologist and other healthcare providers in your clinic, you will find which treatment of these advanced options is going to be the best one for you. As a reference to see where all these different treatments may fit, both those that are infused, those you may inject, and certainly those that are swallowed. This is a really good place to look to just see these different categories. Certainly nothing that you're going to memorize, that's for sure. We also have a chart for psoriatic arthritis, and I also have done one for ankylosing spondylitis. So I hope you find these useful references. The last thing I wanted to go over is some common questions that we get in regards to these therapies. So the one is, do I stop my conventional DMARD, so things like methotrexate, leflunomide, when starting on an advanced therapy such as a biologic? And what I wanted to let you know is because it can take up to 3 months for any of these advanced therapies to be fully effective, it is common to continue your conventional treatments until your next appointment with the rheumatologist. Methotrexate is commonly continued long-term with advanced therapies, and in many cases there's a synergy between these that helps it work better and work longer over a longer period of time. So the big message is, when you're starting an advanced treatment, don't discontinue any of your traditional therapies until you've been instructed to, and any reduction would probably not happen until that 3-month mark. The next one is, do I stop my advanced therapy when I get an active infection? And I will say that it is suggested to hold your advanced therapy until your infection has resolved, as giving a dose while you have active infection can make it advance at a quicker rate and make it more difficult for that infection to go away. More questions. Do I need to stop my advanced therapy if I'm having surgery? Advanced therapies are often stopped 2 weeks before surgery, whereas our conventional therapies, such as methotrexate, tend to not be stopped. It is important to consult with your rheumatologist and surgeon, as it really depends on what type of surgery you're having and what the infection risk is as to how soon before treatment or before the surgery you may have to stop your treatment. We also get the question, can I have a vaccine when on an advanced therapy? And I can tell you that any non-live vaccine can be given while on treatment. This includes your annual flu shot, pneumonia vaccines like Prevnar 13 and Pneumovax, the non-live shingles vaccine Shingrix, hepatitis vaccines, often combined hepatitis A and B in a product called Twinrix, and the tetanus vaccine we refer to as Tdap. These are the most common vaccines we're giving in updating our adult vaccination checklist, and they are all non-live. However, there are some live vaccines, and in the case where this may be required, one of those would include MMR, measles, mumps, and rubella protection. We do suggest that if we can, to give these before we even start an advanced therapy, at least 2 to 4 weeks ahead of time. But if you're already on a treatment and require a live vaccine, you may need to hold your biologic or advanced therapy for a short period of time, and this is something you would need to discuss with your rheumatologist. Even more questions. We get a lot of them, let me tell you. Advanced therapies are expensive. How do people afford them? Well, I hope I've already answered that question by mentioning that there are government-based plans like Trillium, ODSP, private insurance, as well as certainly our support programs that are run through the pharmaceutical companies. And because of all this, we find that the cost of these medications is totally reimbursed through these different avenues. If I get some redness at the site of infection, do I need to stop my treatment? Well, the odd time we can get redness or swelling or a bit of itchiness at the injection site. This is not common, and it doesn't mean it's an overall allergic reaction. It can usually be managed by just warming the injection up ahead of time, so taking it out of the fridge about a half hour before. If we're cleaning the skin with alcohol first, make sure that it has dried before doing the injection. And if we need to, sometimes we'll use an antihistamine about 15 minutes or half hour before an injection, or sometimes even use a steroidal spray or cream to desensitize the skin before injecting. And ice packs could be used as well. But usually we don't have to do anything, but there's ways that we can manage it and still be able to stay on our treatment. And last question, how long does it take for an advanced therapy to start working? So some people are fast responders, and it may start to work within a very short period of time, within a couple of weeks. However, to see the full benefit of treatment, it's normally 3 months that we require. And in some cases, we may wait even until 6 months before we say, hey, is this our best treatment, or should we move on to something else? So yes, you do need to be patient, and I really hope that you are a fast responder.